information. So everybody's more than welcome to submit a paper for that. So we take extended abstracts and papers, and if they're accepted, then you have a chance to present at the conference. So we'd love to see some of you at the conference. So I just want to welcome Ingrid. I had the pleasure of meeting Ingrid in Delft at the International Ergonomics Association Healthcare Systems, Ergonomics and Patient Safety Conference last November, and invited Ingrid to do this, and she kindly accepted, so it's great to have her. She's a physiotherapist by background and an ergonomist by profession, and holds a specialization in the care of older people with over 25 years work experience in the area. And Ingrid's main practice is within the elderly long-term care sector, and she currently leads the physiotherapy services for the community residential homes within the Active Aging Community Care, which is an entity of the Maltese government. Okay, so Ingrid, I will stop sharing and hand over to you, and best of luck with the presentation, and then we'll have time after for discussion. But if people want to, maybe just in the meantime, if you want to just put in the chat who you are and where you're joining us from. It's nice always to know who we're speaking to, and then we'll have time for questions if you want to put those in the chat as well. Great. Okay, Ingrid, I'll stop sharing and hopefully you can start.
Okay, has that got on?
Yeah, perfect, Ingrid. Yeah.
Okay.
Yeah.
So, hi, good afternoon, and thank you so much for inviting me over. It's a pleasure to present my my work. So basically, I'll go through this in 25 minutes as instructed by Mari. Hopefully, I shouldn't be too long, but I tend to be chatty. So this is a presentation of a study I carried out as part of my master's degree a few years back. My master's degree in ergonomics, which I carried out in Loughborough University. It's obviously called the systems approach to patient handling, risk management, and long-term care. Why did I choose to address this topic? Okay, I have to do. You told me, Mari. Okay, I have to change it from here. Yes. Why did I choose to carry out the study within the elderly care sector and within the long-term care sector? Mainly, it is my area of practice, as Mari has already mentioned, I believe there was a need to start looking into risk management for patient handling within the sector that I was working in. The reason being, residential community services for older persons in Malta underwent a change. In other words, that they moved from being, many of our residential homes moved from being mainly homes that only gave hospitality services, and as years moved on and the older persons who were residents in these homes grew older, and the changing needs where older persons were being admitted were more highly dependent. So the role of the homes changed from being homes that mainly took in people just for hospitality services, and they moved to more caring services. So then there was a need that was created where, because older persons were being handled and they were offering more caring services, we needed to set a system in place where patient handling, which could create a very serious safety issue if not done properly, was addressed. And this was possibly a start to my work in patient handling, which I've been carrying on throughout the years. So hopefully, maybe finally, we have things in place properly. Okay, so the aims of this research was to investigate whether the management of patient handling risk could be improved using a systems mapping approach. Basically, I was being qualified in ergonomics. It was something that was the approach, using a systems approach, was something new to Malta, because we did not have many ergonomists on the island, and most of the people that are qualified in ergonomics actually are professionals in other areas. In my case, for example, I'm a physiotherapist. So this was something new, and it was an approach that was relatively new to Malta. I carried out the study within 2 community residential homes for older persons. I chose 2 homes that were, one of them was state-owned, and it was managed by the public service, by the entity that I worked for. The other home was state-owned, but managed through a public-private partnership scheme. In other words, the nursing and caring services were offered through a private company. Now, the aim of the study was not to compare the service given in the 2 homes or the risk management approach that was present in both homes, but it was more to gather information about any limitations or any risk factors that were there that could be present in both areas, be it management through a public service or management by a private company. So the design was mainly qualitative, okay, and what I aimed to do was to build a picture of the situation at the different levels of the organization, seeing that I wanted to look throughout the whole system, okay, and I used the participants to help construct what I termed the reality. So I was actually in the field, all right, I was looking and observing and interviewing people who worked at all levels of the organization, okay, so that's to try and build literally a picture of what was going on and where the limitations were. Okay, so I used mixed method design. I did use some quantitative tools, even though essentially it was a qualitative study, but I did use some quantitative tools, but not actually to create or to get any statistical data out of them that I could to use statistical data, but it's just so that I could actually reinforce or emphasize the limitations. Okay, and I did not need the numerical statistics for anything other than that. You know, so, and we will realize that when I come to the tools that I actually use. Okay, so the research. So what I used was actually I used 3 tools apart from the observation that I carried out and the documentation that I evaluated. Okay, so I used 3 tools. Mainly, one of them was the patient handling observation question set, which is known as the FOX, which is a tool that measures change in safety culture behavior. Okay, it is a tool that is normally administered to people in management, in senior management, or the home managers. Okay, and it covers areas related to policies and procedures, risk assessments, patient assessments, and the general organizational culture of the home. Okay. I administered it as an interview to the home manager, and whilst I was actually, and because it was requested as part of the tool, right, I asked the management to produce the documentation, which I then evaluated regarding patient handling risk management that they may have. Okay, so they have to come up with their assessments, or anything else that they used as part of their patient handling risk management procedures. Is it okay? Am I hurrying up too much? Are you understanding me?
Yeah, perfect, Ingrid. Thank you.
Another tool that I used was known as the DINO. It is the Direct Nursing Observation Tool by Johnson. Okay, and I use this tool because what the tool does is assesses through observation the work technique that's being carried out by the staff. Right, so it has 16 items, and those cover the preparation, performance, interaction with the patient, and results of the transfer. So obviously I picked a number of transferring techniques, and I went into the homes and I watched the staff carry out the techniques to grade whether they are being carried out safely. Okay, and the handling techniques that I chose to observe were bed to chair, turning in bed, maneuvering of the hoist, lying, sitting to standing, and assisted walking. I did not, since the whole aim was not to compare use numerical statistics, I didn't really, it wasn't really an issue how many of each type of transfer I actually chose. I mean, what was being done, I observed. So if it was a bed to chair transfer, I used the DINO for the bed to chair transfer. If that day, that particular resident was being used, a hoist was being used on her, I actually just observe the maneuvering of the hoist. The most important thing is that I intended to carry out to collect 20 data sets from each home to have a total of 40. Another tool that I used was then looking at the residents or at the patients. Okay, so I used the patient perception questionnaire so that I could get a view from the patient's perspective of how they actually feel about the way they are being handled. Okay, and the patient perception questionnaire is a questionnaire that looks at the patient's perceptions of safety and comfort. Obviously, over here I had to include residents, because I like calling them residents in residential homes, who were cognitively intact, who could, following the transfer, sit with me and complete the questionnaire. So for this study, I had to eliminate, unfortunately, I had to eliminate older persons who suffer from dementia or have some form of cognitive impairment. Okay. These research tools were complemented with concurrent observation and the items that I actually, and what I chose to observe was because I set myself a guide through the items on the tools themselves. Okay, so I observed certain items, certain things that were in the tools that I felt I needed to observe in more detail. So I could give myself, as much as possible, very rich qualitative data of what is happening exactly in the field. Okay, the data collection was carried out over 8 weeks in these 2 community residential homes, which I believed were the best homes that I could carry out the study in. And the participants were participants that ranged from both the organization system down to the operational level. So I had the managers, the senior management, down to the nursing and carers, who are clinically effective. And as I mentioned before, I gathered 20 data sets from each residential home. The results, total participants, there were 26 across both homes. Management were the home managers, and then I had the clinical staff and the older persons, which were 13 and 11 in total. I couldn't get a larger sample, mainly because of the limited time. That was very, very time consuming, actually going into the homes and watching the things being done, mainly because I had to fit in with the timetable of the home. So there were limited times when I could actually go into the homes to watch these transfers, because mainly I had to be in the home either early in the morning when the older persons are being washed and changed and transferred out of bed, or else I had to go back in the afternoon where they are being either put into bed or coming out after the afternoon siesta. You know, so it was very, very time consuming. I would hang around the home waiting to see which older person is going to be transferred. Okay, results I got for the safety culture were now on the Fox tool, a score of more than 40% indicated that risk management with regards to patient handling was being undertaken within the organization. Now, my aim was not to compare homes, but the way that the results came out was that one home was actually had a higher safety culture behavior than the other one. But they essentially, both of them showed that there was some form of safety culture within the home going on. Okay, but obviously there was quite a difference. Okay, however, when I came to observe the work technique, the DINO, okay, now on the DINO, if you obtain a score that's less than 1, it indicates that the techniques were being carried out unsafely, and it is a big pity, because all the scores, when I carried out the mean score, it came below 1. Okay, so overall, the techniques that were being carried out were unsafe. Okay, now the most commonly viewed tasks were the bed to chair maneuvering, hoist, and turning to bed. Turning in bed. Sorry, that's a typo. So and they were all on the low side. Okay. However, when you look at the residents' perception, okay, now the scores are on a 0 to 4. Obviously, the highest score is 4 for safety, comfort, dignity, and technique. And the older persons did feel safe and did feel comfortable. So they were not under the impression that what was being carried out for them was not being done possibly correctly or as correctly as it should be done. Through the observation and evaluation of documentation, I got out a number of teams, okay, which then helped me map all the risk factors that and all the limitations that I identified, and I got out these teams regarding the policies and procedures and the legislation, risk management and assessment, training and advice, operations, equipment and environment. So the limitations that I observed through the tools and through the evaluation of the documentation and what I observed myself in the home. By the way, the home and the staff knew that they were being observed. Okay, I split up in these teams, which I then mapped out using an axis map. Okay, so I used the axis map to summarize the results from the tools together with the information that I gathered through observation. Okay, now why did I use axis map? Because I felt it was the best way to show the relationship between the different factors across different levels of the system, and obviously how these could ultimately lead to poor patient safety and decreased quality of care. Okay, now I believe most of us would be familiar with axis map, but for those who might not be, axis map is a type of a systems map that draws on work from Rasmussen back in 1997, the risk management framework, where it was shown that the higher level factors are believed to have an impact on the individual human performance at an operational level. So all the factors at the different levels are linked. Okay, and that is the map that I came up with. Okay, so the map goes through the different areas of the system, starting from the regulatory level, okay, which is external to the system. Okay, here we're talking about the authorities like the Occupational Health and Safety Authority, the Social Care Standards Authority, and the Quality Care or Quality Assurance team, which is the team that audits the services that are being carried out in the homes. Okay, at the organizational level, the senior management and the home management, down to first line, and then the operational, which are obviously what happens at the bedside. Okay, one thing that I hadn't done, which was pointed out obviously by my supervisor, this was a dissertation for my master's degree, is that in my axis map I did not put in the patient, which I should have put down at the bottom and put the arrows up, okay, into the thing. But that was pointed out to me, and I didn't change the map for the presentation, but I am telling you that I should have put at the bottom the patient, okay, with the arrows going up, which because they are obviously affected by what we do. Okay, another reason why I chose axis map is because I felt as I have told you in the beginning, like, you know, this was something relatively new, the system's approach to things like patient handling and safety issue like patient handling was relatively new to the service which I was working in. And I felt that it's a type of mapping that is relatively easy to understand. Okay, and when you're trying to present something new to the people who are working it and to the management at the end of the day, okay, it was something that they could relate with easily. So this was one of the main reasons why I chose axis map and maybe not some sort of more complicated form of mapping. My recommendations that came out of this study, some of which have been implemented, but we are still working at it. Okay, so the implementation of patient handling policy, covering the risk assessment process, guidelines for correct patient handling techniques, use of equipment, maintenance, which were, if you have a closer look at the map, because obviously it was very small, these were all missing, all right, or all very limited within the system. Okay, regular auditing and reviewing of all policies and risk assessment, carrying out regular resident dependency assessments, which would then obviously reflect the need to carry out an updated risk assessment, and also review of staffing levels, because one of the big problems, again, that was pointed out in the thing was that the staffing levels were very poorly planned, okay, to ensure that there were good staff to resident ratios for the staff to be able to carry out things safely and efficiently at the same time. Setting budgets for purchasing new patient handling equipment. There was equipment that was missing. All right, so obviously the staff were carrying out some techniques that were not safe simply because they did not have the equipment, or some equipment was outdated. Okay, review of the home environment. In some homes, because the homes were not originally designed to house persons who needed, house older persons who needed to have a care around the bed, or nursing around the bed. Some of the home environments where possibly the area around the beds was too small, and the space itself created a potential hazard. Okay, dedicated updated training for all staff, and I believe with competency assessment following that. Okay, and obviously in my opinion, very important, change management to instill a better safety culture within the organization. And I've come to the end.
Great, Ingrid. Thank you so much. I mean, it just shows what is possible when you apply human factors to and systems analysis to these complex problems, like all the different things that, you know, that are uncovered. I mean, it's a really rich picture from the patient's perspective, staff perspective, from reviewing policy and guidelines, and then to come up with the AXI map. I mean, it's great, really well done. If people have questions, please, you know, just turn on your mic and join in. And we might stop sharing, Ingrid, and we could chat then if that's okay. And I suppose I'll just start off the questions. Maybe I just the ethnographic observations, because you've been working in this field for a long time. Was there anything that shocked or surprised you, I suppose, is my first question. And then the Dino score, is it unsafe for staff or for patients, or both? You know, when you say there were unsafe practices, is it unsafe for staff or for patients, or both, or for residents, sorry, or both?
I'll start with the second one. The Dino is direct nursing observation tool. So basically it observes the technique of the nurses. But in my opinion, at the end of the day, when you've got that occupational health and safety is related to patient safety. So if I believe if the nurse is carrying out a technique that is unsafe for herself, generally it will be unsafe for the patient as well. Okay, yeah. So that is generally my opinion. But as such, the Dino is looking at the nurse technique.
Okay.
And then was I shocked with anything? As you've already explained, I come from the older person background. I practice in residential care. One of the things that pushes me so much to try and correct these practices is because you think you've seen it all, but you've never seen it all. You're always coming up with something new. So really, no shocked at that point, no. But till this day, sometimes I am shocked with certain things they do.
Okay. Cora, you had your camera on. Did you want to come in, or anybody else want to come in and ask a question of Ingrid?
Sorry, no, I actually had my camera on by mistake. I was trying to unmute, but just to say thank you very much for an excellent presentation, Ingrid. That's really interesting. I suppose maybe I know it wasn't the purpose of your research, but maybe can you give us a sense of the rate of harm that's occurring, or the number of incidents that would have occurred at the two sites, and whether or not that's getting better over time, or is that outside of the scope? Is that, yeah?
the study per se did not, the aim was not to look at the
Yeah.
incidents that are occurring. Unfortunately, most of them go unreported.
Yeah.
So we don't have exact statistics. But as I tell you, as I told you and I told Mari before, I think I've seen it all, but then you realize that you haven't seen it all. So I don't have exact statistics, but I can tell you that these things, I'm not sure it doesn't only happen in Malta. These things keep on happening.
We certainly
Thank
have
you.
issues with falls all over the health system. Yes.
Yeah.
That's for sure.
Sarah, did you want to come in there? You're on mute there, Sarah.
Firstly, sorry, apologies, Ingrid. I missed the very beginning. And therefore, I have a question that you've probably already addressed. But thank you very much. Very interesting. I was just wondering about the profile of the homes that you had in terms of how representative they are, because I know certainly the way sometimes homes have residents that are really highly dependent, and then in other places, and not so much. So what was the what were the homes? And as I say, I apologize. What was the profile of the patients? Apologies that I missed the beginning.
Basically, since I was looking at, the aim wasn't really to compare homes. The aim was to come out and to find the limitations that are existing. So since I was looking at a range of transferring techniques, obviously I would have had a mix of residents. So if I was looking at the hoisting technique, you would generally have an older person who's relatively dependent because they are non-weight bearing. So, but then if I'm seeing a sit to stand, or I'm seeing a simple transfer, manual transfer, a walking transfer from the bed to the chair, I would have an older person who is on his feet. So I had identified a number of transfers that I wanted to, or that were commonly done in the homes, and I basically I would go inside the home, and the manager would identify a number of residents who were cognitively not impaired, because I need to do patient perception questionnaire, and whatever transfer that was going to be done to them, I would observe it, and I would because the aim wasn't to carry out statistics to see which transfers were being carried out badly. The aim was to identify limitations, to identify whether the transfer was being done safely. Now, irrespective of whether it was being done with the hoist or whether it was a sit-to-stand transfer, I wanted to see the limitations of whether things were being done safely. So, the profile of the homes, they are community residential homes. They admit anybody who has a Bartel above possibly 4.
Right. Okay.
Okay. So you can get anyone who's relatively independent. So anyone who is totally dependent, because at a Bartel of 4, there are people who are really.
Right. And I suppose it'd be interesting to see whether cognition comes into it as well. You'd excluded those because you wanted them to fill in your patient perception questionnaire.
Because I wanted to have the patient's perception as well, which then I obviously forgot to include in my Axi map, because that is my fault. I could not. Unfortunately, yes, we do have these issues when you're carrying out studies where you need, but it's a pity, because we should, study the transferring of people with dementia, because the fact that they have behavioral problems, or they might have poor communication problems, does prevent sometimes an increased hazard. Which we need to consider in our risk assessment.
Absolutely, it's very interesting to see that the inclusion of their opinions as well, which is great. Thank you very much.
Okay. Thank you.
Great, Ingrid. I don't think there are any more questions. Cora, is that a question important? That sometimes service users can perceive that something is safe when in fact, based on objective observation, it is not. So that's an interesting finding, Ingrid, that, sometimes the residents can feel things are safe when objectively you're assessing that it's not safe.
Well, which is exactly what happened, because I could obviously see when we look at the Dino, when you see that they all came out with lower than 1, which is the Dino is safe at 1. So but the residents felt safe.
Yeah.
So so in reality, yes, they were not perceiving the fact that it was what was happening was unsafe. But then at the same time, it's something I didn't go into the biases today. These are people who know that they are commenting about people who are taking care of them every single day. And sometimes you might, obviously, a certain bias comes in because they might not actually be telling you the truth. So they might be actually scared to comment because they think that it's going to have negative repercussions. Even though I did advise them that whatever they're telling me is going to remain confidential, there always remains that certain doubt that what they tell you might not be exactly the truth.
Yes, and it's always an issue in patient research because they're so vulnerable, and residents, and they feel this might affect their care. Yeah. Ingrid, that's great. Really interesting. You're going on to do further study, which is great.
Yes, that.
So we look forward to hearing from you again in the future in terms of this issue. I'll just share my screen again to close if that's okay.
Okay.
And I just want to give a shout out for our conference again. Anybody who's interested, we're having our Irish Human Factors and Ergonomics annual conference on the 12th of June. It's a Monday in TU Dublin in Grangegorman. So the call for papers is open at the moment. So we'd be delighted to have some papers. So just want to thank you, Ingrid, very much. It was a great talk. Thanks to everybody for joining. And just keep an eye on our website. There's always interesting things coming up. So thanks, everybody. Thanks, Ingrid. And thanks for joining us from all over the world. It's great to see people from all over the world. So it's lovely to see. Thank you. And look forward to the next one. All right. Thanks, everybody.
Thank you. Thank you. Bye-bye now.
Thanks. Bye-bye.
Bye-bye.